Hi, good afternoon, good morning for some of you. We are with you all today in a Heart Talks of Women Heart focused on cardiomyopathy. Cardiomyopathy is a group of conditions that affect the heart muscle and can change how the heart pumps. I am Selena Gore, the CEO of Women Heart, and I'm so pleased to be with all of you today. Thank you for spending this next hour with us. Today's session is being recorded and we'll leave time near the end for question and answer, so please do submit questions at any time. And as always, this discussion is meant to be educational and not a substitute for medical advice from your own clinician. For anyone new to us, Women Heart is the national patient-centered organization for women living with and at risk of heart disease. We've been around since 1999 and we support, educate, and advocate through trusted resources, peer-led support networks, and our amazing trained WomenHeart Champions, and you'll meet two of them today. And we do all of that to advance equitable, high-quality care in every community. We are so grateful today for the sponsored support from CPKC for making this program possible. Thank you for your generous sponsorship. Cardiomyopathy can develop for many different reasons: genetics, pregnancy-related changes, inflammation, or sometimes without a really clear cause. And while it can affect anyone, many women experience delays in evaluation and diagnosis due to systemic issues in cardiovascular care. Symptoms may be attributed to stress, fatigue, aging, menopause, or postpartum changes rather than investigated as potential heart conditions. Today's session is part of Women Heart's effort to bring clarity, improve understanding, and help women recognize when something deserves follow-up. We are joined today by our expert speaker, Dr. Mariko Harper, a cardiologist specializing in cardiomyopathies, and two of our wonderful Women Heart champions, Gwen Mays joining us from Maryland, and Charity Watkins joining us from North Carolina. They're going to both share their lived experience and help connect the clinical information to what women actually go through. Now, a number of you submitted your questions during registration, and one question was, please go into complete detail about what cardiomyopathy really is and how to stay healthy with it. And I could not think of a better way to summarize our session with you all today. So over the next hour, we'll start with a clear explanation of exactly what cardiomyopathy is, why it develops, and the major types, including peripartum cardiomyopathy and hypertrophic cardiomyopathy. We'll discuss what symptoms can prompt further evaluation, what the diagnostic journey typically includes, and the systemic factors that can contribute to delays in women's care in particular. And then we'll hear our champion stories, highlighting different cardiomyopathy experiences and wrapping up with general guidance for women living with cardiomyopathy, followed by your questions. So let's jump in with our clinical expert. Dr. Mariko Harper is a board-certified cardiologist with specialized expertise in cardiomyopathies, including hypertrophic cardiomyopathy, or HCM, and heart failure. She's the medical director of the Hypertrophic Cardiomyopathy Center of Excellence at Virginia Mason Franciscan Health, where she leads a multidisciplinary patient-centered program focused on comprehensive diagnosis, advanced imaging, and individualized care using shared decision-making, what every patient deserves. Dr. Harper is a published author, a frequent national and regional speaker, and a principal investigator for ongoing HCM clinical trials with a strong commitment to patient education and collaborative care. Dr. Harper, it's such an honor to have you join us today for this conversation. We've been looking forward to learning from your expertise and exploring this topic together. So let's do it. Let's jump right in. Can you start by explaining what we mean when we say cardiomyopathy and what actually is happening in the heart muscle?
Absolutely. It is such a pleasure to be here and with all of you. So, it sounds a little bit funny, but when a patient comes to me for the first time and they've never been to a cardiologist before, sometimes I use the analogy of a cardiologist is sort of a general contractor. And if you're trying to buy or fix a house, the house is your heart, and there are
Mhm.
different parts. And that is a simplified way of thinking about the different type of heart conditions, because a lot of people say, well, heart disease runs in the family. Well, that could be the same thing as somebody saying, I've had, people, house troubles in my family. People have had troubles with their house. Well, what does that mean? So cardiomyopathy is really focusing on the structure of the house.
Okay.
So I say, well, okay, if you're walking in the house and you're inspecting the house, you look at the structure, the walls and the windows. That's what we can look at with things like echo or ultrasound. The walls of the house are like the muscle of
Mm.
the heart. It's what's doing the moving, it's what's propping up the whole structure. Then you can have problems with plumbing. That's like coronary artery disease or heart attacks. You can
Mm.
have problems with electricity. You might need an electrician checking out your lights. And all of these things go together. But the issue is, what is the primary problem? And in
Mm.
cardiomyopathy, the problem is with the muscle. So if we look at the word cardiomyopathy, it has Greek and Latin roots. Cardio means heart, myo means muscle, and
Mm.
pathy or pathos, pathology. So at the most simplest, it is a condition or disease affecting the heart muscle. And it can have many different types and subtypes. But if we have that framework of thinking about it
Mm.
as an issue with the muscle or the structure of the heart, we can imagine that the issues can be, when we're looking with our pictures, like our MRIs and our echoes, it can be an issue with the heart being too dilated or too big, stretched out. It can be an issue with the heart being too thick or stiff, like with hypertrophic cardiomyopathy, or it can even be an issue with things infiltrating the heart. Things like cancer, very, very rare. Things like abnormal proteins, we hear of amyloid, for example. And these abnormal things can infiltrate the walls and make it look thick, but it's a bit different than hypertrophic cardiomyopathy, where it's just the cells expanding. So cardiomyopathy is the umbrella term of all heart-related conditions relating to the heart muscle as the primary. And there we then do classifications. And oftentimes those classifications are anatomical. And what we see is the heart too big and stretched out. We call that dilated cardiomyopathy. Is it too stiff?
Mm.
Or is it too thick? And oftentimes there's some overlap. And oftentimes dilated hearts can also be stiff, and
Mm.
thick hearts can also be stiff. But once we characterize what that type of cardiomyopathy looks like with our pictures, like with echo or heart ultrasound, then we come down to what is causing it. And that's when it gets really complicated. But we know that frequently it's an overlap of genetics, environmental, possibly immune, and other things that we just don't know yet. It's an overplay of what makes us unique. But
Yeah.
yeah, things like hypertrophic cardiomyopathy it's the number one genetic cardiomyopathy worldwide, and it's fairly common, 1 in 200 to 1 in 500 people, but very underdiagnosed, especially in women, which is why I think today's conversation is really needed.
Yeah, and you hit on the most common, as you say, type of cardiomyopathy. You also talked about dilated cardiomyopathy. Can you talk a little bit about the peripartum cardiomyopathy as another example? Obviously, is unique to women.
Yes. So peripartum cardiomyopathy is a combination of probably some genetic factors and hormonal factors unique to certain women. There's also some races that are more likely to be affected, and it tends to present in the early postpartum period with hormonal fluctuations, and it is a subtype of a dilated cardiomyopathy.
Okay, all right. You've already started to mention some of the factors or conditions that can lead to cardiomyopathies developing. Um, what are some signs that would prompt a person maybe potentially suffering from a cardiomyopathy or a clinician even to consider cardiomyopathy as a possible diagnosis?
So the symptoms can be pretty heterogeneous, meaning non-specific, and there's a lot of them. But frequently, the early signs include fatigue, and shortness of breath, often when we're trying to exert ourselves, harder to climb up stairs or carry heavy things, or feeling very lightheaded or weak after doing that activity. Over time, a subset of patients, especially with more of the dilated cardiomyopathies like peripartum cardiomyopathy, can develop what we call overt heart failure symptoms, which is not just the heart dysfunction, the weakening of the heart muscle as it dilates, but to the point where the heart is having a hard time pumping enough blood forward that some of it's going backwards. What
Mhm.
does blood going backwards look like? It can mean congestion. So the lungs can fill up with some fluid, the belly can fill up with some fluid, and the legs can fill up with fluid. That's often described as leg edema or swelling in the feet. Starts often at the toes and then comes up as there's more and more fluid being retained. Some people carry it more in the belly, so it can be hidden. Or again, in the postpartum period, it can be completely thought to be normal fluid changes. But
Mm.
as fluid increases, often people feel very short of breath when they're trying to lie down flat as the fluid fills up the lungs. There can be coughing. We call it cardiac asthma or cardiac cough. But you can imagine that with all of these different symptoms, it's easy for people, especially with something like pregnancy, to say, oh, that's normal pregnancy. Of course you're tired. Of course you're short of breath. You're out of shape, or you haven't slept well with the baby, or you just have a minor cold. So it's a difficult diagnosis if we're not vigilant, but the symptoms are typically fatigue, acute shortness of breath that worsens, especially with trying to be active. Sometimes issues with swelling and fluid retention. And we talked about some of the electrical issues or plumbing issues. Sometimes it can be a chest tightness or pain or palpitations because the other parts of the heart are starting to act up.
And Dr. Harper, when you say fatigue, I just imagine that this should be a kind of fatigue that maybe you've never experienced before, right? Not your, I'm going to say, run-of-the-mill fatigue or something that you are familiar with.
Exactly. And fatigue is so subjective and
Yeah.
it's so easy to dismiss, especially in women, right? Where people are, you're fatigued. It's like, oh, well, just live with it. But
Yeah.
oftentimes my patients tell me, I knew something was wrong. This was not normal for me, but I didn't have the words, or I didn't have a way, I didn't have a mechanism or a connection with my cardiologist or provider to be able to insist that this is not my baseline. This is not normal. But that's what it is. Your gut instinct, and you know yourself well. You might not have all the words and you may not be able to argue that this fatigue is different, but
Different.
oftentimes you
Yes.
know something's off.
It's the differentiation. And I think when you say vigilance, that's what I think about, like being vigilant, knowing your body well and understanding when it's really a difference
Exactly.
of fatigue. Many women experience delays, as we've talked about, in getting evaluated for cardiac symptoms for reasons that are unrelated even to the disease itself. Can you speak a little bit to how systemic factors can sometimes impact how quickly or how slowly cardiomyopathy is recognized in women?
Absolutely. So we can borrow from something that might be more commonly understood in the lay public, heart attacks.
Hmm.
Heart attacks present a little bit differently in women. We're more likely to have breathlessness or pain in the arm or in the shoulders or in the jaw, rather than just the crushing chest pain that we assume with men. Doesn't mean women don't have it, but women sometimes present with slightly different but equally concerning symptoms. It's about detection. One, a lot of the media is out there telling us the symptoms are what men are described as having, and
Yeah.
also our internal biases. Most cardiologists are men. That's changing, but when I trained, it was less than 10% board certified cardiologists were women. And the studies that we as cardiologists do were selecting the men. So we had a lot more data where the studies looking into these conditions are done in men, and they describe the male presentation of these symptoms. They also describe the bias when we're seeing a patient and what we think about first. So we're much more likely if a man comes in, he says, my chest hurts, saying, oh, maybe they're having a heart attack, than if a woman says, my shoulder hurts. And maybe we say, well, that might be something different. So there are multiple systemic issues dating back to decades of research that focused on patients that do not look like us or maybe behave like us as women, internal biases and who you're seeing, especially if they're men, the treatments being specifically designed and implemented more on men, and
Mhm.
also the fact that we as women, when it comes specifically to cardiomyopathy, we are more likely in many of them to experience it, but it's felt to be more rare because it has been less studied and there's less awareness.
Absolutely. Let's bring Charity and Gwen in. And before we go deep into each of your stories, which we'll do for sure, I'd like to ask just a quick question. And Gwen, we'll start with you, and then we'll go to Charity. And the question is, can you share the type of cardiomyopathy that you were diagnosed with, and what you knew or didn't know at that time, including your initial reaction to hearing the diagnosis? Let's start with Gwen, and then we'll go to Charity. Gwen, you're on mute.
Thanks, Selena.
Yeah.
Um, I have hypertrophic cardiomyopathy. I have the obstructive form of that, which means that the thickness, or I call it the lump in my pump, the thickness in my ventricle and the muscle, as it's been described, creates an obstruction to the outflows. So I have a very loud murmur and I have a diminished flow through my heart because of this obstruction. I was diagnosed actually many, many years ago. I was officially diagnosed in 1988, and the condition was not very well known at the time. It actually even had another name to it. I was in my 20s at the time, living in Washington, D.C., and there was no internet, there was no real patient advocacy group. And because of my mother's family history of sudden cardiac death in her family, it really was not a difficult diagnosis for the cardiologist to make because of my loud murmur. I had had fainting episodes. I was very thought of myself as athletic, but again, I felt like I had a rubber band around my chest. I just couldn't take deep breaths. And so my diagnosis was relatively accurate and spot on. The challenge is that it was considered a terminal illness at the time. There was really no treatment options, and it was quite scary. There was not much to offer me other than wait and see. We don't know.
Wow, that's a lot. That's such a good trailer for the movie to come in a few minutes, Gwen. It's a good pitch. Charity, let's hear about your type of cardiomyopathy and diagnosis.
Sure. So I was diagnosed almost 10 years ago with peripartum cardiomyopathy or pregnancy-related heart failure and with the dilated cardiomyopathy. And that was after receiving misdiagnoses initially of the flu. And
Mhm.
then after that, postpartum depression. And so thinking about that link between your psychological health as well as your physical health definitely showed up for me. I later on went through genetic testing because my mom and my dad both had heart failure as well. However, that was not considered during my prenatal care, even though that information was shared with my provider. When I went through the genetic testing, I was found to have a genetic mutation called the TTN genetic mutation, which directly affects the heart muscle. And my dad was told that he had the same genetic mutation. And for my daughter, had to go through the same testing, and she was found to have that same genetic mutation as well. So we're talking about three generations of potentially cardiomyopathy arising. And luckily, through my story, I'm able to help both generations.
Amazing. Thank you so much to Gwen and Charity. And Dr. Harper, sort of look at those two different experiences of diagnosis and talk about the diagnostic process and what that typically looks like. So when someone presents with symptoms that raise concern for cardiomyopathy, what does the diagnostic process typically include, and how do you differentiate cardiomyopathy from other potential heart conditions?
Absolutely. So starting off is being very comprehensive in getting the history right and the family history. And honestly, I think we as cardiologists are generally not trained to ask enough questions. We ask about the imminent questions, but we don't put enough effort. Well, it's not effort. We just don't have enough recognition and training to ask about our history. This
Yeah.
will become more and more important as precision medicine improves and genetic testing is more available. But there is so much we can learn. And patients also have some agency in this. They can ask their family members and do their own history too. Because I get a lot of people coming back the second time saying, hey, you know what? Well, I actually did talk to my aunt and this, and that's, they didn't just have a heart attack or, or they didn't have that. They actually had this. And then I found out this relative and that relative. So know your history, but also know your family history, because we get a lot of clues. And that is the very first thing that makes us first think, ding, 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 cardiomyopathy. And many cardiomyopathies have a genetic root. But as far as testing, oftentimes physical exam, as Gwen mentioned, that murmur is obstruction or a leak. There's different qualities of the murmur. So I don't know if Charity had a murmur, but if her heart is dilated, the valves can often spread apart and temporarily leak. And we can hear a leaking murmur. And we as cardiologists know how to tell them apart. On the other side with Gwen, if her heart was too thick as the blood's trying to leave a valve, it's almost like having a garden hose with your thumb over it. Instead of a laminar flow, it's suddenly this harsh, thick, loud murmur. So we can get hints, but make sure your cardiologist is doing exams. The new generation, sometimes we rely too much on our sophisticated imaging, but an exam and history and family history gets you right on that track. But then the next test is the echo. We should also do an EKG. Most of us do EKGs for screening for all sorts of conditions. Frankly, there are few, but rarely do we make the diagnosis based on the EKG alone. But it gives us some important information. Even what your heart rate is, it gives us a sense of how hard your heart's working. But when we do the echo, so that's non-invasive pictures of the heart with an ultrasound, it's about a 1-hour appointment. That is where we see everything. So we can see if the heart is thick, like Gwen's was, and we can see if the heart is dilated, like Charity's was. We can see if the heart is likely squeezing too tight and too robustly, like Gwen's, or not enough and weak, like Charity's. And from there, we can make the initial diagnosis before we go on to specific and more advanced imaging, which is not necessarily necessary for every patient, but things like cardiac MRIs, stress tests, special nuclear studies can also help refine the diagnosis, can make it more accurate, and also do something that we call risk stratification, or give us a sense of how bad it is in that moment, the prognosis, or what therapies may or may not help.
And Dr. Harper, are there particular points in this diagnostic journey or the evaluation where women might need to speak up or ask for more information?
Absolutely, and all the time, but especially if you feel dismissed at that first visit. That first visit, especially both of these conditions we're talking about, right? In Gwen's case, it sounds like she was pretty extremely symptomatic, and she had a cardiologist who knew about her history. So ask the right questions. So that really helps. But oftentimes when women go in and they say they feel short of breath, or they feel a little tight, and they feel not right, sometimes it's one quick test and say, oh, you're fine. We do a basic test. But in a lot of these conditions, unless you're really delayed in diagnosis, which is actually a really bad thing, both mentally, physically, and prognosis-wise, the early signs and symptoms are subtle, but they're there. But we need somebody who understands that this is not your normal, understands that there could be something, but we might need to look a little harder than ordering just an echo and saying, oh, things are good enough.
Yeah. Yeah. And just as a side note, I know that so many cardiologists, including my own, right, work on this model of 10-year risk, right? So if it's not going to happen within the next 10 years, you don't have to worry about it. But, I think the more we're learning about how much we can know about our future self 20 years on, the more I feel like there's an impetus for us to take action, both as patients and as clinicians. So I think that goes along with precision medicine that you're talking about, Dr. Harper. Coming back to Charity and Gwen, I'd love for each of you to sort of continue talking about the journey from symptoms to diagnosis, and then most importantly, as you look back on the experience, what you would want other women to know if they're still themselves seeking some answers. So let's start with Charity.
Sure. Thank you, Selena. So my, I guess, journey to diagnosis took a bit of a few turns here and there. I was 30 years old, first child. I was in my PhD program. So I took my pregnancy very seriously. I always call it my first research project, most important one. And I did all of the things. However, much of what I look back on now in terms of the birthing classes never talked about cardiac issues during pregnancy. And so when I had my daughter, it was an unplanned cesarean delivery. And I also experienced hemorrhaging before I actually left the hospital. And the response to that was really painful. Manual removal of blood clots with no pain medication. So that was my
Oh my
very start to my diagnosis. And I had no idea what was going on. I thought I was going home to recover, even though I had no idea what recovering from a cesarean delivery looked like. But I was, kind of taking it in stride. I was excited to have my daughter home. We were starting our, family as three. But it was the symptoms that started pretty much, I would say, within the first couple of weeks after got back home, that became alarming. When I was in my second trimester, going into my third, I was walking 5 miles. And then all of a sudden, within a couple of weeks after getting back home, I wanted to get back active, but I found myself struggling to even walk up a flight of stairs. And it became worse. I had the nagging cough that wouldn't go away. Actually, the term that you provided, Dr. Harper, is the first time I've heard that terminology in terms of congestive asthma. And it continued. I also experienced nausea. I lost my appetite. I also experienced this radiating pain in my left arm into my jaw. And that was actually what prompted me to go to the ER. However, I should note that before I went to the ER, I went to my OB first before my 6-week appointment to tell her what was going on. And that's when I was told that I had maybe the flu. No test done to determine that. And then when I continued to tell her, because I was very vocal, that, hey, something's going on. I don't know if this is normal or not. I was then told that maybe it's postpartum depression. And I am a social worker. I am very aware of what depression looks like and how it can show up in folks. And I didn't think that was it, but I also was afraid of being considered a difficult patient,
God.
especially being a Black woman and not wanting to come off as if I am a problem.
Mhm.
And so that kind of pushed me towards just following through with what she said until I went to the ER with that pain that happened twice within a weekend. It was very painful. The palpitations also occurred. I only received an EKG, not a physical exam, during my time at the ER and waited there 5.5 hours
Oh
not
my
to be seen at all. And it was actually when I went to campus health 2 days later, where the physician actually did a physical exam and he saw that I had the edema in my legs. He also saw that I had fluid built up in my lungs. He did a X-ray and showed that I had fluid in my belly. And so I was then taken back down to the ER, the same one that I was at 2 days ago. And later on that night, I was admitted into the cardiac intensive care unit and was told that my heart was functioning around 5 to 10%.
Wow.
And so it was very close to me not being here to talk with you all right now. Very fearful of not being there for my daughter, who was at that point 2 months old. Am I going to be here for my first Mother's Day? I wasn't sure. And so it was a very scary experience. I'm glad to be on this side of it and also helping with Women Heart with spreading the word on what this looks like, especially for young women. I think the takeaway I would share with folks is knowing your family history. I actually am an associate professor with college students, and I tell them all the time, know your family history as well and share that information. But I will also say, don't be afraid to do your own research and partner with your physicians. If there is something that is going on in your body because you are the expert of your own body, then please share it. And if it's still a concern, even after you share that information, ask for another opinion.
Yeah. Wow. That's amazing. Thank you for sharing that, Charity. Gwen, how about your experience looking back and what you would want women to know?
Well, my case is a little bit of a slow burn compared to charities. Hypertrophic cardiomyopathy, as we've mentioned before, is probably more common than most people think. And there's variations. It's considered a spectrum disorder. My mother was a genetic carrier. Have the gene mutation, but my mother had zero symptoms, and I had symptoms at birth.
Wow.
And even as a young child, could not run and play in the fifth and sixth grade, and that was very confusing. I wanted to be a cheerleader. I tried out, when I was in college, I tried to go on sorority fraternity formals to Gatlinburg, and I was always sweating, and I was thinking, oh, I need to lose weight. And I just love the way women make up excuses. I just want to say I've made up them all. I didn't get enough sleep. I ate the wrong thing. I need to lose some weight. I'm out of shape, etc. So I would build upon what Charity and others have said, particularly in cardiomyopathy. There is such a strong family history that not only do you need to really pay attention, we as women know our bodies, we know our menstrual cycles, we know our ebbs and flows of our emotions and our hormones, is to really be aware of when you feel off. And when you feel off is maybe an intuition, it's kind of a quiet nudge. And I know when I was younger, I felt off. I felt that I could not do what everybody else in my step class did, or I couldn't walk in the Peachtree Road race, or I could not stay awake at night, or I would get really tired walking at the mall. And these were just symptoms that I had. So I'd say to women, first of all, regardless of your age, is to realize cardiomyopathy and the symptoms of cardiomyopathy can surface and express themselves at any age. I've met plenty of women who are in their 60s and 70s who are first having symptoms. Then there are people much younger than myself, even as a child. So cardiomyopathy will and can express itself for a variety of reasons at any age, and to really not only know your family history, but really know when things are off for you. I would also just one other point is that I think all of us have to move on from the fear that we are a difficult patient. That has become somewhat of a phrase that we all think of. It feeds into our insecurities often about raising questions, not knowing the right words to use, not knowing how to express ourselves, feeling rushed in the doctor's office, knowing it took us 3 months to get an appointment. We are not difficult patients. I like to use the word determined. I am determined, and I've used that with all of my care providers, and I've had over 20 cardiologists say, I don't mean to be difficult, but I'm determined to get at X, Y, and Z, why I can't sleep, or why I'm waking up at night, or why I'm having chest pains, etc. So those are thoughts that come to my mind that hopefully will encourage women to just be diligent about caring for what they feel isn't right.
Thank you, Gwen. The word that comes to my mind when listening to both of you is partner. You're looking for a provider or a clinician, a physician who's a partner so that you don't have these feelings of inconveniencing them, right? That they are on the same page as you are. They are just as curious about what's going on with you as you are. That's really right, what we're looking for, what we're aiming for. Dr. Harper, to come back to this idea of a woman who perhaps is newly diagnosed or is still in the process of being evaluated, what are sort of the most important steps that they can take to manage their heart health right now?
Absolutely. So, just as a comment on the difficult patient thing, I think the first thing that all of you need to know is if you feel dismissed and unheard, that is probably not the right partnership. Now, we don't all have the luxury of choosing, all of our providers and shopping for them, but that is not normal, and that should not be the standard that you accept.
Yeah.
And doesn't mean everybody is the right fit. And it doesn't always mean that everything that you're feeling in the heart area is a problem with the heart. But somebody who doesn't respect you enough to hear you and have the time for that does not understand what you're going through, and it's probably not the right fit. And furthermore, I think that person probably is either younger or has not realized how much he or she has missed. Because just talking about HCM, the statistics are that the average patient, from the time that they have onset of symptoms of chest pain and shortness of breath, 3 to 4 providers and 6 years before the right diagnosis. And for women, it's a little bit later, about 7 to 8 years. So we know in cardiomyopathy that we are not great at diagnosing things, that our patients are seeing multiple providers with the same symptoms, and we only catch them when they're too severe to ignore. That not all the time, but unfortunately that is realistic. And so believe in yourself and find the right relationship whenever you can, because you are right. Doesn't mean everything's catastrophic. It doesn't mean that something is terrible with the heart. But if you don't feel heard, if you feel dismissed, then there is a probability that someone will have a misdiagnosis with that relationship. Now, as far as what can we do to keep ourselves healthy, right, is know yourself, love yourself as much as you can, to stand up for yourself, and really, maybe it's very generic, listen to your body, but it is that thing of do not assume that the problem is something else, right? We are so good at it. And the number of patients I have as they get older and they've been living with symptoms for years, be it one type of cardiomyopathy or not, they say, well, I just thought I was out of shape. I thought this was normal aging. I thought I had put on too much weight, or I've been really stressed at work. We as women are very good at taking care of everybody else before we take care of ourselves. But we really need to, if that thing in the back of our head saying something feels not right, listen to it and get that voice loud and upfront so that we're catching these things early. And part of that is taking that time for yourself to do that daily check-in, right? So routines are really important, regardless of what type of cardiomyopathy you may have or are at risk for. Doing your daily walk, right? Or whatever exercise you like. I tell my heart patients who have coronary disease, that's your daily stress test. You don't need to come in and get a stress test on a treadmill every few days if you're doing your daily walk and one day that feels off, right? So take that time to exercise, take that time for yourself to meditate or whatever it is that quiets your brain enough that you can listen to those signals, eat the right foods, sleep, have relationships and community, and give yourself that time so that input can go in and you know yourself a bit more. And all of those things just help us live better, fuller, longer lives, regardless of if you have cardiomyopathy or not. But you're far more likely to pick up on symptoms early and be confident enough that those symptoms are not okay to bring them to the attention of your provider earlier.
So just to give some very specific tips to women, what questions or statements can help women clearly communicate their concerns during appointments? And when might it be appropriate to seek a second opinion or a referral to a specialist or another provider in general?
I think if you feel dismissed, or if the decision, if you're given a diagnosis without a clear plan for follow-up or a treatment plan, that is probably too simple. And so if you're still having symptoms, it's one thing if they say, well, let's see how it goes, wait 6 weeks or so and come back and see me. But if they just give you a willy-nilly diagnosis, or this is probably that, with that, and they're not invested enough to come back and not necessarily order tests, but see you back to see how you're doing, and you're still having symptoms, that's probably not the right fit. But sorry, ask me the first part of that question again.
What statements or questions would help women clearly communicate their concern?
So I think coming in, I always ask patients, the first thing I say is, before I say anything, I want you to spend the next few minutes briefly telling me why you think you've been referred, or why are you here to see me, and what's been going on, because that narrative sets the stage. If you come in and we just do a little survey and then we're doing check boxes, your story doesn't get out there. And I'm going to make a lot of assumptions as to why you're there. And what I learn a lot is that patients come in with very different expectations or symptoms or things that they want to talk about. Sometimes what their doctor sent them for has nothing to do with why they want what they want to have worked up. So have that narrative and make sure you take, it's 3 minutes out of even a 15-minute visit, 3 minutes. Have a little narrative of what you are there for. So it can be something, sometimes my patients tell me, I have no idea. My cardiologist told me I had to see you. I have some kind of cardio something. And other people say, no, this has been running in my families. I've been living with this for years. I keep telling my cardiologist this. And they said, well, maybe you have answers. That's a very different conversation.
Yeah.
But I think temporal stuff, so telling me what your symptoms are, how long they've been there, when they started escalating, and why now? Why are you here to see me now? Is it because things have tipped over? Or have you had this long thing where you've been feeling really frustrated and not heard? Those things give me a sense of how long they've been going on, where your journey is, and allows me to ask the questions that really narrows it down and makes the most of our visit.
That's great. Gwen, what helped you feel more confident navigating your care, and what message would you share with women who are feeling overwhelmed or unsure about what's happening with their symptoms?
Selena, that's an excellent question. I feel like, having managed this condition literally my entire life, there was really a turning point about 20 years ago. Actually, it was my first time to go to the WomenHeart Scientific Leadership Symposium. And there were events around that time that I felt put me actually in jeopardy or in harm, because the care providers, unfortunately, were not familiar with hypertrophic cardiomyopathy. And I was misdiagnosed and mistreated in an emergency situation. I'll leave it at that. But the point is that I really began to realize that it's my responsibility to be the captain of my care. And that I had a chronic illness I was going to have my entire life. I'm not going to outgrow a genetic mutation. And it was sobering at the time, but it also taught me that in every circumstance, I have to be the most prepared person in the room. So before every appointment, I have notebooks, I write down questions I want to ask. I bring it out. It's visible in the exam room with my pen. I've sometimes asked if the sessions can be recorded. It shows diligence. It shows that I am keeping up with the care. I do not expect the snapshot of my blood pressure, my heart rate, and my EKG that one time. It's been 3 months since I've been there, 6 months or a year, to be really reflective of my entire day-to-day up and down health conditions. So I want to keep my own records. But I feel like what's really helped me more than anything navigate through this is to realize that it is my job to do the very best I can to make sure that I live with this condition. And that there are now treatments and there are options and there are clinicians, and that the overall responsibility really rests with me. And I think that that has probably been the thing that has added to my confidence, so that encourages me to keep up with research, to get involved in patient advocacy, to tell my story, to come prepared to meetings, continue to ask why, and to ask follow-up. I never leave a doctor's appointment that I don't ask, What did we not talk about that we should have? And invariably something will come up. Might be
Yeah.
a med needs refilling. How's my emotional well-being? How's my anxiety doing? Have I met another patient? And it actually generates, I think, an interest to show that there's always something that maybe I forgot to ask that needs to come up.
Great advice. Great advice. Charity, what would you say in terms of your navigating your own care and messages you'd like to share with women?
Sure. So I would actually go back to something that Dr. Harper had actually mentioned at the beginning. As someone who studied Latin through middle school and high school, I value the meaning of words. And what I would say is that I have moved from focusing on the pathy part to focus on the cardio part because I'm still here.
Mm,
I'm a researcher professionally, but then I became one personally, not only for myself, but also for my family and my community. I would say that my interest and dedication and commitment to advocacy has truly deepened through my experience. I have learned about the importance of lived experience being considered a form of expertise and being able to promote that not only in the spaces I'm able to occupy as a patient advocate, but also bringing others along with me. I definitely listen to my body very carefully, and even if it may not be a big concern, if there's something that I don't have an answer to, I'm going to look for an answer. And so I don't push away my concerns as something that I should just ignore because it can't be something big because
yeah.
I've already experienced the big.
Yeah.
So I would say clearly being able to connect my providers as well has helped with that. So connecting my general practitioner with my cardiologist, even having my doctor's pediatrician a part of some of these conversations, my mental health professional. Like I am looking for interprofessional care at this point because I
Yeah.
think that's what's actually going to allow for me to live the best life that I want to live. And honestly, that's really my goal.
Thank you, Charity. You know, Gwen and Charity, you guys are wonderful examples of what I consider to be expert patients. And I think for those of us managing chronic conditions, that's what we should be aspiring to. That we are expert in our own care, expert in our own symptoms, expert in our lived experience, and that you go in with that confidence, right, to every visit. We're not done yet, but I do want to take the moment to thank Dr. Harper and Charity and Gwen for providing us such a rich conversation today, intertwining expertise, experience, insight, vulnerability, right? All of that, I think, is what has made this such a rich conversation. And what we've got in our last 5 minutes is some time to go into some questions that I think we've got from our audience. So let me just get right into it. We've answered some of these already, so I'm going to skip the ones that we've already talked about. But one question here, Dr. Harper, is there any evidence linking elevated LP little a, lipoprotein little a, with preeclampsia or long-term cardiovascular risk after pregnancy? And how, if at all, does that relate to conditions like peripartum cardiomyopathy?
Yes, so LP little a is elevated in about 1 out of 5 individuals in the United States, and it is a risk for increased inflammatory atherogenesis, meaning increased inflammation of our blood vessels and what we call endothelial dysfunction, and increased risk of multiple different types of cardiac events. It is most commonly checked as a risk factor for high cholesterol leading to risk of coronary artery disease or heart attacks. That said, there is data that very high levels of LPA early in the pregnancy may predispose to increased risk of gestational hypertension or high blood pressure during pregnancy, as well as peripartum cardiomyopathy. And the higher it is, the increased the risk. And so it is an inflammatory marker, and inflammation, especially in the endothelium or the inner lining of the blood cells, leads to lots of different badness, including increased risk of heart attacks and strokes. And that's how we think about it most commonly when we're talking about cardiology, but also remember that we have our new blood vessels forming in the placenta and whatnot, and all of them are affected. So in the long-term effects of gestational hypertension, we know that it's an additional risk factor for future cardiovascular events. So yes, LPA is important. It is a rare signal. It's not a very common thing that we check and expect to be elevated, and that's a risk factor for peripartum cardiomyopathy and gestational hypertension. But there's absolutely a link, and that should be discussed in people who we know that is a very elevated, especially extremely elevated when there's family history or personal history.
And Lp(a) will be checked more and more as time goes on, right, Dr.
It's
Harper?
becoming more and more common. I think it's very, very reasonable that you should be able to expect it checked by pretty much all of your providers at this point.
Absolutely. Is this a new heart disease post-COVID? So I guess they're talking about cardiomyopathy post-COVID. And is there a link, I guess is the question, is there a link between cardiomyopathies and COVID?
So the simple answer is no, it's not new, and no, it's not related to COVID. But this is the asterisk. COVID is an infection. There are many, many different infections, COVID and whatnot, that have two different effects on the body. One is the acute viral syndrome, right? That's the flu-like symptoms. But the second is how it affects our immune system. And for some people, consider it just another environmental or a toxic signal. When we get an infection, our body produces an immune response to get rid of that infection. Sometimes that immune response becomes deregulated. So instead of just a small, appropriate immune response, it becomes the spiral. And that inflammation can cause certain types of cardiomyopathy and other types of conditions, including what we remember associated with both COVID and rarely, but with the vaccine, the myocarditis. So myocarditis is muscle cardio, right? So heart muscle itis or inflammation. And can I say for sure that COVID never causes cardiomyopathy? No, pretty much every virus out there can cause certain types of cardiomyopathy. But so far, we don't have any data to think that COVID is unique or has necessarily caused a significant uptick in them. When we're talking about the cardiomyopathies that Charity and Gwen have, those are genetic and have been present for years. They run in our lineage from generation after generation. The genetics and the scientific sophistication to diagnose them properly has only caught up in the last 50 to 60 years, and really in the last 10, 15.
Absolutely. Oh my goodness. I mean, we obviously can stay on this call for a much longer time. But I do need to cut it off here because I know we've got some hard stops. A really heartfelt thank you to Dr. Harper, to our WomenHeart Champions, Charity Watkins and Gwen Mays, for sharing your experiences and expertise, and to all of you for your thoughtful questions and your engagement today, and all the hearts and all the beautiful congratulations that we see coming through. As we close, we want to highlight two new WomenHeart resources. We recently published an infographic on cardiomyopathies designed to help women understand this group of conditions at a glance, and an accompanying educational module created to support WomenHeart Champions in reaching their communities. So both of these resources explain cardiomyopathy as a category while recognizing the important differences among specific diagnoses. So please explore those and share them with others who may benefit. As we've already mentioned, the recording of today's session will be available in a few days, so please visit womenheart.org for additional resources and follow WomenHeart on social media and stay up to date with all of our upcoming Heart Talks and tools, and let us know what other topics you want to hear about. Please, everyone, take care of yourselves, take care of your hearts, and we look forward to seeing you in a future WomenHeart event.